Mr. Chairman, members of the committee, thank you very much for the invitation to be with you here this afternoon. My name is Frank Catalanotto. I'm a children's dentist. I have been involved in academics and education for about 40 years now. And for roughly the last 20 to 25 years, I have focused a lot of my attention on the issues of access to oral health care and oral health policy. And I currently chair a Department of Community Dentistry, which is essentially a Department of Public Health at the University of Florida College of Dentistry. My presentation is the one in your packet entitled New Mexico Needs Dental Therapists. What I'd like to do is start off first with what I call some of the indicators of the access problem and some of the effects of the lack of access to oral health care. One point not in my slides because the data was only released on Friday was a report commissioned, survey commissioned by Oral Health America, Harris Poll survey, which looked at senior citizens' access to oral health care across the country. And in that survey, 35% of lower income seniors indicated they had not seen a dentist in 4 years, and the primary reason they cited for that was costs. The issues I wanted to address are emergency room visits for preventable dental conditions and then the effects of lack of access to oral health care. The first study that I would mention was a report presented by the Pew Children's Dental Health Initiative last year, which looked at emergency room visits to hospitals for dental conditions which are absolutely preventable. And what they showed was a 16% increase in just 3 years from 2006 to 2009 across the United States, over 800,000 visits to dental emergency rooms. That report and my own experiences in Florida prompted me to write an editorial called Pay Me Now or Pay Me Later. And the purpose of that editorial was to illustrate that what happens in an emergency room for dental care is antibiotics and pain medication and go see a dentist tomorrow. So all those costs produced no change in that patient's dental health. They still had to seek a dental care or a dentist the next day. And my argument would be, if I could take those costs that we have paid through our insurance premiums, through Medicaid fees, and turn them into preventive dental visits up front by a dental therapist, by a dentist, by a dental hygienist, you would save money long term and you would save pain and suffering. However, the most tragic report that I present to you is next, just released last week in a respected dental journal, which showed that in the 9-year period from 2000 to 2008, not only were there emergency room visits, but there were 61,000 hospitalizations for a preventable dental condition at a great expense, of course, but even more tragic, over that 9-year period, 66 deaths from an absolutely preventable dental condition. This is a personal tragedy. This is an economic tragedy for this country, and I'm sure for your state. I do not have information on your state's emergency room visits, but I know they are high. So what's the effect, other effects of poor dental health? And I'm only going to cite to you 2 relatively recent studies which looked at school performance of children who had dental pain interfering with their learning. I preface this by saying, what's the way out of poverty? What's the way out of poverty for our low-income children in this country? It's education. But if you cannot learn, you will not succeed. You will end up at a job behind the McDonald's counter with a cash register because you don't have appropriate education. Both of these studies have clearly documented children in dental pain don't learn as well as other children. And again, I'll use a personal example. Gadsden County, Florida, when we did a survey, we have the same problems you do in Florida. We examined every 3rd grader in that school. On the day of the examination, 1 in 5 children reported dental pain. So who are these people with disparities of access, bad oral health? They are the poor. They are racial and ethnic minorities. They're poor people in rural and underserved populations. They are working families. People with jobs, but they don't have dental insurance. People with hourly wages who, when their child has a dental problem, have to take off 4 hours of work to get their child to a dentist because, and that dentist might be 2 hours away in your state, as it is in many others. My concern is this is now cutting across economic groups because it's not just the poor anymore. It's middle-class folks. American Dental Association's own data has shown a drop in dental visits unrelated to the recession that we are just coming out of, that has been going on for a decade in a recently published report by the American Dental Association, a drop in adults seeking dental care. By the American Dental Association's own words, cost, the major factor. So what are the solutions that I see for this? There are two major approaches to this in my experience in looking at the literature and my own experiences. First, we have to do a better job of educating the patients, particularly lower income patients, about the importance of oral health, about the importance of maintaining their teeth. But to do that, we need to use evidence-based procedures. I'm a researcher by background. I'm driven by data in the decisions I make. We need culturally competent practitioners who look like and come from the communities of these patients so that they can relate to them. Practitioners trusted by these patients. And then we need an adequate workforce. Ms. Blackwell mentioned that you're short of 400 dentists. I would argue with you that more dentists is not necessarily the solution, and it is the most expensive solution that you can look for. I was in this state 10 years ago consulting with you, with a group that included folks from the Pew, and we absolutely recommended back then, and I would stand by that now, do not go with a new dental school. Do not put a dental school in your state. Develop your residency program in general dentistry at the University of New Mexico. And yesterday afternoon, I got a chance to visit that program. You obviously listened to the advice of the committee. But there is another solution, and that solution are some of the new oral health workforce models that are out there. Why do I stress these new workforce models? Number one, they are less expensive to educate. Number two, coming right out of high school, going into these programs, they can easily represent the communities where they come from. There's nothing wrong with dentists providing dental care. Dentists do a great job. I'm a dentist. I'm proud of what we do. We don't look like our patients. We come from, very frequently, we come from middle class and upper middle class families. For years, we were a profession dominated by white males. We don't look like our patients even today. The new models of oral health workforce look like the patients. On your slides in my packet is a point I talk to my students about, the culture of poverty. Most of us don't understand true poverty. Some of us might, by our backgrounds. But I talk to my patients, my students, about taking care of patients who come from an entirely different background, who come from true poverty. Lots of us have been late paying a bill, but we know there's a backdrop for that. Patients in poverty don't. They need solutions that address their needs. Many dentists don't participate in the Medicaid program. Why? Logical reasons. Reimbursement is awful. I come from a state with about the worst reimbursement in the United States. Administrative hassles. I talk to the dentists that have problems with Medicaid in Florida. I would agree with them. They have concerns about Medicaid patients, but I also think they don't understand Medicaid patients. They don't understand poor patients. They don't understand the needs of working families. New oral health workforce models, such as the one promoted by the American Dental Association, community dental health coordinators, or the one we're presenting to you today, dental therapists, can address those issues. However, I see disadvantages great advantages to some of these models, but I also see disadvantages. The biggest disadvantage I see to the community dental health coordinator is all they can do is case management. The second disadvantage is there's no evidence base to support that they are in fact effective. There's a disadvantage to dental therapists across the country in that there are multiple models. But you have a model being presented to you here in New Mexico that looks like it to be absolutely supported by the prior literature and that fits the needs of your state. a little bit more about why I support dental therapists as I come to a closure. 50 countries across the world use dental therapists, and they've been doing so for 90 years, up to 90 years, New Zealand being the first. The evidence is unequivocal. Safe, effective, and cost-effective care. You can't argue with the data. Again, I'm a researcher by background. I'm driven by data decisions. Dentists will sometimes say to me, but how can they be competent in providing the procedures that I do? How can they be competent in doing fillings on teeth? It took me 4 years of college and 4 years of dental school. And you're educating these individuals in 3 years, as the proposal is in New Mexico. The answer is actually quite simple. We as dentists are trained in what I would say about 500 different competencies. No wonder it takes that long. Dental therapists are trained in about 90 competencies. That's all. A limited scope of practice. I will also tell you that the dental therapy program that I have visited in Alaska now 3 times, those dental therapy students did more of certain procedures that I did when I was a dental student and that any typical dental student does today. Procedures like stainless steel crowns and what we call pulpotomies, I don't want to get technical on you, and silver restorations and things like that. They're well trained in a technique called motivational interviewing, which is how to change a patient's behavior. A lot of dental schools don't teach that. I have read the literature on dental therapists. They work. I've been to Alaska 3 times to look at the dental therapy program up there, which is one of the 2 in the United States, in Alaska and Minnesota. They have a major emphasis on prevention as part of their training. I've spoken to folks who have educated them. I've spoken to folks who have employed them. They are really pleased with the services that they provide. In conclusion, I'd just like to say, I am convinced that dental therapists are a great fix for you here in New Mexico as one of your solutions because of your rural, geographic isolation of your communities and the cultural diversity of your state. Thank you very much for your time.
Thank you, Doctor. Thank you very much. Appreciate that.